Next speaker is Chris Vapiano, and he's going to talk about how to manage lumps, bumps, and dumps on the cornea.
Thank you very much to the organizing committee for inviting me. So I'm talking about managing lumps, bumps, and dumps on the cornea. Okay. I do work with some companies, but none directly related to this talk. I'm going to really talk about three kind of corneal concerns here. Epithelial basement membrane dystrophy, Salzmann's nodular degeneration, and band keratopathy. Now these are conditions that we all see pretty much every day or every week in practice. And we'll talk about things that every one of us in the audience can do pretty much at any time, as opposed to some of the very complex surgeries that were just talked about. So epithelial basement membrane dystrophy, also anterior basement membrane dystrophy, EBMD, ABMD, different names. It's reduplicated epithelial basement membrane causing several potential problems. One is loose epithelium leading to recurrent erosions, these painful episodes, and two is irregular astigmatism. Now this irregular astigmatism may or may not be obvious just on slit lamp exam, and you may or may not see it on corneal topography or K readings, but you need to look out for it. The irregular astigmatism obviously can affect the vision, but if you're considering surgery, whether it's cataract surgery, refractive surgery specifically, this irregularity can lead to inaccurate K readings and inaccurate IOL power measurements. It can affect the post-op quality of vision, and it can worsen post-operatively. It may be very mild preoperatively, worsen post-operatively, and cause significantly decreased vision. When you diagnose these conditions preoperatively, it's the patient's problem. When it's only diagnosed post-operatively, it becomes a surgeon's problem. So you need to keep that in mind. Sometimes it's very obvious. It's a significant EBMD centrally, causing irregular astigmatism and monocular diplopia. This is another relatively obvious one, EBMD with some anterior haze. If you're not exactly sure, you can put fluorescein on, and you can see significant negative staining here, which indicates that this is going to be visually significant. Here's one that's a little less obvious, and if you're just doing a quick exam, you may not see it that well, but just put fluorescein and it becomes extremely obvious that this is going to be a problem if you don't deal with it. So to treat or not to treat, if there's negative staining centrally, or if there's irregularity on topography or K readings, then if there is that, then it does require treatment. If you don't see that negative staining and you don't see irregularity, you can probably get away with leaving it alone from a symptom standpoint or a pre-op standpoint. But if it's there, you should definitely consider treating it if they're symptomatic or if they're going to undergo surgery. And then typically I'll wait about 6 weeks after surgery, allow epithelium to smooth out, heal, K readings to stabilize before repeating the biometry, and you may want to repeat it twice to make sure it's stable before considering surgery. How do you treat it? Well, there's several different ways. There's epithelial debridement alone. You can do debridement and then add diamond burr polishing, or debridement and then do excimer laser PTK. Debridement's very, very straightforward. Just take a blade and just remove all the epithelium, irregular epithelium, and loose and irregular basement membrane. Sometimes you can do it with a sponge, but typically a blade, you really need to get all the basement membrane out. I will usually do a diamond burr polishing myself, debride it, and then I take the large diameter 5mm diamond burr and just polish Bowman's uniformly over the entire cornea for about 5 to 10 seconds. And this is the diamond burr that I use. It's the big 5mm diameter burr. Here's a patient preoperatively, and then 6 weeks post-op diamond burr, very smooth, clear cornea. Another patient preoperatively, and then 6 weeks post-op, smooth, better vision, a little bit of haze sometimes, comes and goes on its own. Sometimes you can use steroids to help. You can use excimer laser PTK, and the key here, once you do your debridement, it's just a 5-micron uniform ablation. You don't need to go deeper than that. All right, second topic, Salzmann's nodular degeneration, these creamy white, moderately elevated nodules, usually peripheral, sometimes central. They may be associated with the EBMD, can cause dry eye type symptoms, but also irregular astigmatism, even if it's fairly peripheral. Here too, to treat or not to treat, if there's irregular astigmatism, then you should consider treating. And again, you want to wait about 6 weeks post-treatment to recheck any biometry. Here's a pretty obvious one, significant visual symptoms from this. Here's a less obvious one, but reaching into the visual axis. Topography here shows irregular astigmatism with 12 diopters of cyl down there. Here, a little less obvious, but topography irregular astigmatism with 5.5 diopters of cyl here. How do you treat it? You can do lamellar keratectomy with a blade, plus or minus diamond burr polishing. Often you can get a nice, smooth basement membrane, but sometimes you can't, and that's where I like to use excimer laser PTK, and I'll usually combine it with mitomycin. With that, I'll remove all the nodules and then use mitomycin 0.02% for 60 seconds on an 8mm sponge and irrigate with saline. Here's preoperatively a nice big Salzmann's nodule. 5 months post-op, beautifully smooth and clear. Here's a little less obvious one. You think, maybe I don't really need to treat it. However, topography shows irregular astigmatism here, affecting vision. Not a huge amount of cyl here. 6 months post-op, beautifully smooth and clear. Nice topography now. Interestingly, they have kind of some real normal astigmatism there. And then lastly, band keratopathy is gray-white calcium deposition, numerous etiologies, often related to chronic inflammation, but sometimes it's just idiopathic. If it's central, it can affect the vision. If it's peripheral but it's elevated, it can also affect the vision. And then if it's irregular and elevated, it can affect comfort too. So the treatment here, you want to work them up for an etiology if it's not already known. And then the treatment is a pretty straightforward EDTA chelation. The key with the chelation treatment is you need to remove the epithelium over the entire area of calcium. The EDTA will not get absorbed into the band if there's a little piece of epithelium on top of it. So usually I use a 15 blade and then use 3 or 4% EDTA just on a cellulose sponge. Sometimes it's 5 minutes, sometimes it's 10 minutes, sometimes it's 45 minutes, depending on the thickness of the calcium. Here's preoperatively. Sometimes I'll just thin out a WEC cell and lay it on there, go see a few patients, and then come back. This is immediately post-op, nice and clear cornea. Here, pre-op, immediately post-op, no calcium there, and then 2 weeks later, beautifully healed and smooth. So in conclusion, corneal irregularities and opacities are quite common in everyday practice. They can affect comfort, clarity, and corneal curvature. It's especially important to diagnose before cataract or refractive surgery, so it's the patient's issue and not your issue. There are numerous techniques to identify them. I think negative staining is great, and then topography, and then even manual K readings can really help a lot. And they're excellent treatment options that you can do right in the office and get super results. Thank you very much.